Hi, my name is Dr. David, neurosurgeon specialized in pain management. Today's topic is cervicogenic headache, which many people suffers from. As cell phones become popular around the globe, the cell phone lifestyle deteriorate posterior neck. This video is quite challenging to understand, so you'd better listen carefully to this video for your long-term headache relief. It is estimated that cervicogenic headache account for about 15 to 20% of all chronic headaches. It's quite a lot. Cervicogenic headache is the type of headache originate from cervical degenerative or traumatic problem. The term cervicogenic headache was first coined in 1983 by Norwegian neurologist Ottar, and in 2004 it was classified as a subtype of headache by the International Headache Society. Cervicogenic headache is a type of headache that is caused by a problem in the neck, specifically the upper cervical nerves and the trigeminocervical complex in the cervical spinal cord. It is thought to occur due to the convergence of these structures, resulting in pain in the retro-orbital area, the front and side of the head. Cervicogenic headaches can also be caused by middle or lower cervical spine disorders, which is thought to be due to the connection between spinal cervicothalamic tract and the trigeminocervical complex. In short, cervicogenic headache is the result from pain communication between brain and cervical spine. The dorsal ramus of the second cervical spine nerve gives up branches to the splenius capitis and semispinalis capitis muscle, and then becomes the greater occipital nerve. The ventral ramus of C2 branches to the levator scapula, the scalene muscles, and the upper fibers of trapezius. The superficial medial branch of third cervical spinal nerve, C3, is also known as the third occipital nerve and supplies the skin over the posterior aspect of head, as well as the joint between the second and third cervical vertebra. The first, second, and third cervical spinal nerves are located within the trigeminocervical complex and can stimulate the second-order nerves within it, leading to the development of headache. The diagnosis can be challenging as the symptoms may be similar to other types of headache and may involve the bidirectional neurotransmission between the upper cervical nerves and trigeminal nerves. The most common cause of cervicogenic headache is the dysfunction of the second and third cervical joint, which is make up about 70% of cases. Other cervical joints, such as the third and fourth cervical joints, can also be involved, but to a lesser extent. X-ray imaging is used to evaluate the bony structures and can help identify any degenerative changes or fractures that may be contributing to cervical headaches. Computed tomography, which is called CT scan, and MRI are also used to evaluate the soft tissues such as the spinal cord, nerve root, and intervertebral disc, which can also be cause of cervicogenic headaches. CT scans can show detailed images of the bones, while MRI can show detailed images of the soft tissue such as muscles, tendons, and ligaments, as well as nerves and blood vessels. In addition, MRI can also help to detect any abnormalities in the brain and blood vessels that may be contributing to headaches. Imaging tests such as these can help to identify underlying causes of cervicogenic headache, which can guide treatment and management. Cervical artery dissection, and also called vertebral artery dissection, is a condition in which there is a tear in the inner lining of the vertebral artery, which can cause bleeding and swelling inside the artery. This kind of headache can be very severe, similar to brain subarachnoid hemorrhage. Cervical artery dissection is rare, with an incidence about 1 in 20,000 people following chiropractic manipulation of the neck. This kind of cervical dissection of artery should be differentiated to the cervicogenic headache. In this video, I will additionally explain about ultrasound-guided facet joint block. As shown in this image, the patient is placed between the ultrasound and the operator, and the procedure begins in a lying position on the side. By positioning the ultrasound on the imaginary line that runs from the highest part of the neck along the mastoid process, the articular pillar can be identified. In this state, the out-of-plane technique can be used for injection treatment, and the ultrasound can be rotated 90 degrees for in-plane technique injection treatment, which is safer. The injection agent is mainly 0.25% of lidocaine and about 1 cc per site, and it is recommended to use dexamethasone if using a steroid. The greater occipital nerve is known to be partially involved in the neuromodular effect of headache. It is associated with not only cervicogenic headaches but also with other types of headaches such as tension type headache and cluster headaches. Greater occipital nerve block is effective for these types of headaches, and repeated nerve blocks are more effective than a single block. Recently, ultrasound-guided greater occipital block has been widely used. The patient is placed in the lateral decubitus position, and the ultrasound probe is positioned between transverse process of the first cervical vertebra and the spinous process of the second cervical vertebra, where the greater occipital nerve runs. The injection is typically made in the fascia between the inferior oblique capitis and the semispinalis capitis. Well, in summary, diagnosis of cervicogenic headache is very important for the treatment plan, and using X-ray or MRI or CT scan is very important to exact diagnosis. Also, doctors can use ultrasound-guided injection to relieve cervicogenic headache. Thank you for listening to my video, and I hope that everybody will release from headache. Thank you very much.